Hi, my name is Schütz and I'm presenting our work on interactive shape sonification for tumor localization in breast cancer surgery on behalf of my co-authors Trishia Chemaly, Emmanuelle Thien Doan, Jacqueline Tsai, Christoph Leuze, Bruce Daniel, and Nassir Navab. Our work focuses on breast cancer, and one of the two most common procedures for removing breast cancer is a lumpectomy. But unlike a mastectomy, where the entire breast is removed, lumpectomy is a breast-conserving procedure where only the cancerous tissue and a safety margin around it is removed. However, it is hard to precisely locate the tumor, and here are a few reasons why. Firstly, preoperative imaging is done in a different position than surgery. For example, mammography might be used during diagnosis. During mammography, patients are in a sitting or standing position. However, in surgery, the patients are lying on their back. And because the breast is deformable, the tumor location and shape will change from preoperative to intraoperative. To localize breast tumors during lumpectomy, breast cancer localization systems have been developed. However, these systems only provide sound feedback on the location of the seed, which is a small marker implanted into the tumor during biopsy prior to surgery. But no information about the shape is provided from these systems. And lastly, after surgeons have made an incision, there's no visual indication if a tissue is cancerous or not. These circumstances leave surgeons guessing the tumor margin and often cause cancerous tissue to remain in the breast, leading to about 15% of patients requiring reoperation. And this is why we present an auditory display that sonifies the seed and the tumor margin location. For this, we require a preoperative supine MRI scan, meaning an MRI scan taken while the patient is lying on their back. Based on this 3D medical image data, we can extract a mesh of the breast and the tumor volume. We then get the location of the probe and the seed using electromagnetic tracking. We compute the distances between the probe and the seed and the probe and the margin, and also do a surface projection bottom up of the tumor margin and seed region to the top of the skin. We do all of this to lastly be able to sonify the seed and the tumor area. We also evaluated the usability and accuracy of our concept in 3 user studies. In the first study, we compared 3 sonifications in an abstracted 2D setup with 12 participants. We did this in this abstracted way to determine whether users can actually precisely locate and mark shapes using sonification. In study 2, we tested a refined shape sonification on a silicone breast model with 21 participants. Again, they were tasked to locate and mark the tumor margin and seed location. And lastly, in study 3, 4 breast surgeons used shape sonification to locate, mark, and remove the tumor volume from agar breast models. As I already mentioned, in study 1, we compared 3 sonifications: beep, rhythm, and synth. Beep represents a status quo sound feedback used by surgeons in the operating room today, and rhythm and synth are 2 proposed shape sonifications. Beep only sonifies the distance to the seed and no tumor margin information is given. Then we tested the first of the 2 sonifications, rhythm. Here the distance to the seed and the tumor margin are sonified with a beat sound that changes instrument. A xylophone sound is played when above the seed, and a marimba sound is used to indicate the tumor margin. Unlike rhythm, the sonification sonified the tumor and the seed with two distinct sounds. A synthesizer sound indicated the tumor area, and a ticking sound the seed. To evaluate the accuracy of the sonifications, we computed the overlap of the ground truth and the drawn tumor shape. On the basis of this overlap, we calculated the Dice coefficient and area ratio. We further computed the Euclidean distance between the ground truth and the drawn seed location. Our results showed that the use of shape sonification leads to a significant increase in localization accuracy. The Dice coefficient indicates a greater overlap of the drawn and ground truth tumor for both of the novel shape sonifications, rhythm and synth. We also saw that there was a substantially decreased area ratio of drawn over ground truth shapes for both of the shape sonifications compared to the status quo beep. But there was no significant difference in Euclidean distance between ground truth and drawn seed locations. We further collected qualitative feedback from the users regarding the three sonifications. They said that beep was easy to understand, but it does not provide tumor shape information, nor does it indicate a direction to the seed from the current location. One participant said about rhythm that the sounds were very pleasant, but I got confused about which tone indicated the seed. Synth was ranked as a preferred sonification by 75% of the participants. One person explained, "I really like the consistent sound, it made the boundary easier to find." With this feedback in mind, we built on the synth sonification and tested the improved version called Tsai against beep in study 2 and 3, this time on the 3D surface of breast model. The beep sonification remained the same as in study 1. Like synth, the Tsai sonification again provides feedback on the distance to the seed and the tumor shape with two distinct sounds. However, this time, the seed is already audible within a wider range around the tumor area to make initial localization quicker. During study 2 with the non-surgeons, we saw that Tsai significantly improved the accuracy of the localization task, and we saw this for the tumor margin indicated by the Dice coefficient, and we also saw this increase in accuracy for the seed location indicated by the Euclidean distance. But there was no significant difference in area ratio between beep, the status quo, and Tsai, the newly proposed shape sonification. For study 3 with the breast surgeons, we analyzed pre- and post-study MRI scans that we had taken. Here, we used the scans to compute the volume of the ground truth and the resected tumor volume. Our results showed that Tsai significantly improved the localization accuracy, again indicated by the Dice coefficient. However, due to the small number of participants, no significance was found for any of the other measures. We again collected qualitative feedback. One breast surgeon said about beep, which they currently use in the operating room, "It only helps to localize the seed, so you have to estimate and guess the tumor size and shape." They further said about beep that it was hard to distinguish the edge of the lesion with as much confidence as when the sign was on. About Tsai, they said, it helps give shape and size approximation of the targeted tumor, and it's very fun to use and offers more accuracy in identifying the tumor boundaries and seed. Of course, our studies do not come without limitations. This concept was tested in a simulated setup, not accounting for breast tissue deformation or acquisition of appropriate pre- or intraoperative medical images. Consideration of these topics would be key to achieving application of this concept in clinical practice. Nevertheless, we provide evidence that shape sonification can increase the accuracy of breast cancer localization. We hope that our work on this exemplary use case will help to promote broader application of audio feedback in medical applications and beyond. For more details, please refer to our paper, and if you have further questions or want to engage in a discussion about the topic, don't hesitate to contact us.